Well, welcome to the final lecture for Nursing 103, Week 10, Chapter 88, Digestive Disorders. Let's get this going. Share screen. There we go. Let's start this up. There we go. So, Chapter 88, Digestive Disorders. This is going to play quite a large part. I know I say that about just about everything, but this really does play quite a large part in your patient's overall health and the course of illness. Let's start with a basic review. So back to anatomy and physiology. The major organs of the digestive system, major organs within the GI tract, starts in the mouth, ends with the anus. And of course, from the nursing standpoint, your bowel movement starts when the fork full of food hits the mouth and ends when, it ends on the nurse's shoes. Yes, you will likely be pooped on at some point or another. Our major organs within the GI tract. Accessory organs, though, not directly within the GI tract, but are a part of digestion. And that's the liver, gallbladder, and the pancreas. Lab studies, CBC. Well, consider this. Consider why the CBC could tell you what's going on with any sort of a digestive disorder. Red blood cells. Well, all cells. They are made of proteins. And where do we get the building blocks for these cells? For any and all cells, we get it from the building blocks for those proteins and those proteins themselves from taking in food, digesting it. So CBC can show you various things. Take the red blood cell, for instance. Not only are proteins needed to build the red blood cells themselves, but iron is also required to form the hemoglobin molecule that fills those red blood cells, hopefully fills those red blood cells. So a digestive disorder, lack of protein in the diet, if you don't have the building blocks, you can't build the cells, or lack of iron in the diet, or malabsorption of iron in the diet can lead to differences in your cell counts. Routine blood chemistries, because we get the components that we look for in these chemistries from the digestive process. We're also looking at liver function tests. The liver being an accessory organ to the digestive system. Other things that we might note are the in blood chemistries, besides the liver function tests, would be enzyme levels and electrolyte levels, okay, and blood sugar levels. Pancreatic dysfunction can lead to very high levels of glucose in the bloodstream or low levels of glucose in the bloodstream. I'm getting ahead of myself here with my mind is 2 words ahead of my mouth. CEA, serum cholesterol and triglycerides. These can indicate not only digestive disorders, but dietary issues as well. High cholesterol and triglycerides, of course, leading risk factors for heart disease, related to the amount and type of food that's being taken in and how it's being absorbed. Urinalysis can show if liver is failing, you will have, or the pancreas is not functional, you will have things spilling into the urine that shouldn't be there. And then stool tests, and obviously digestive tract, but cultures and sensitivities to see what sort of bacteria are growing in there. If there is blood in the stool. Now you'll note that, so here was fecal occult blood testing. Occult, we're not talking about wearing hoods and dancing around a bonfire here. We're talking about hidden. That's the meaning of occult. So what we're looking for is hidden blood in the stool, what is not obvious. If you have a stool sample for a patient and there's very obvious blood in there, then the HEMA test, the fecal occult blood test, is of absolutely no use, because there's not hidden blood in there, there's actual blood showing up. Radiography, barium studies, upper and lower GI, so the patient is drinking a lovely milkshake concoction containing barium, which shows up on radiographic imaging. Anyone who's ever had this knows that it tastes sort of yuck, chalky. No, it's got a lovely berry flavor to it. Tastes like berry sidewalk chalk. But these are to give us a picture of what the inside of the GI tract looks like. And then a cholecystogram. Right, so using your medical terminology training, all right, cholecysto. So this here is looking at the gallbladder itself, right, going in and looking at, does it have stones? Is it inflamed? Cholecystogram. So cholecysto gallbladder gram picture of. So what do we think? True or false? If a client is unable to maintain a liquid diet completely, he or she is allowed to have a small meal 24 hours before the GI evacuation. What do you think? 24 hours. Seems reasonable, right? No. So we're looking at GI tract, and these will be visual examinations when they're going in for a colonoscopy or an EGD or any of these other scope procedures. It really needs to be clear, clean, evacuated, so that we can see everything that's going on. Liquid diets, enemas, are a lovely product, probably the most misnamed, or the most horribly named product in medicine. Go lightly. If you have ever experienced a colon cleanse for a procedure, Go Lightly is a lovely formula that is filled with electrolytes. The patient drinks it, and the order is generally administered Go Lightly until clear, meaning what's coming out the other end is the same color as what's going in through the mouth. I'm very serious about this. This is I have had patients who just sit me on the commode, turn on the TV, give me the stuff. I will sit here and drink it until it's clear. And when they say clear, they mean clear. Because need to be able to. The reason we're doing this scope is because we are looking for issues, polyps, cancer. Need to get a visual examination, and if there is fecal matter in the GI tract, you can't see. Right? So endoscopic procedures, so endo, outside, and scope, right? So these are direct visualizations. Now if you take all of these, gesturing at the screen like you can see what I'm looking at, You can take all of these. Now we've got an esophagoscopy. Looking at the esophagus, right? Esophagogastroduodenoscopy, or EGD. Because if you have to say that 3 times fast, EGD is much simpler, means the same thing. So esophagus, gastro, stomach, and duodeno, that's a duodenum, the start of the small intestine. Okay. Endoscopic retrograde cholangiopancreatography, okay, also known as an ERCP. So when they're talking retrograde here, when you think of the flow from the gallbladder and the pancreas, when you think of the flow, it's moving from the gallbladder, from the pancreas, into the GI tract. All right, that would be the flow. Retrograde meaning we're coming back against that flow to get into those structures. So that's the retrograde portion of it. But again, direct visualization. We're looking at vessels coming in for the gallbladder and the pancreas. Gastroscopy, that's fairly simple. Colonoscopy, again, fairly simple, going directly into those areas and visualizing. Sigmoidoscopy or proctosigmoidoscopy, so we're not going as far up the GI tract, looking at the sigmoid colon or the rectum of the sigmoid colon. Note here, rare complication, rare, happily, of any endo is perforation, right? Meaning that the camera itself, the process, ends up breaking through the wall of the GI tract. This is especially concerning as within the GI tract, it is not a sterile environment. Bacteria grow and thrive there. They're part of our digestive processes. However, outside of the GI tract, bacteria growing, then that creates an infection. And these can lead to peritonitis, sepsis, seizure, coma, death. So rare complication, but something to be looking for in a patient who has had an endoscopic procedure. Would be signs of infection, would be signs of hemorrhage. Right? Sounds an awful lot like the things that we would be looking for from a surgical procedure. Pain, inflammation, and pain and inflammation do go together. And anesthesia complications, because happily you're not really awake through all of this, or signs of infection. And happily, these are fairly common procedures anymore, and we know what to look for. All right. Biopsies. So bio, life, or by life, opsy, visualization. So very literally looking at life. So with endoscopic procedures, lower and sometimes upper GI tract as well, we can take biopsies. And then we're looking for, normally looking for cancer in the biopsies. Polypectomy, removing removing polyps from the colon and checking for cancer, for cancerous cells or just abnormalities. There's, it says here, liver biopsies. Now, for liver biopsy, this can be a little bit scary because a liver biopsy runs a huge risk for bleeding, for hemorrhage. Liver is very highly vascularized. All of the blood flow from the GI tract returns through the liver, through the hepatic portal vein, and then is filtered there. The function of your liver. This is one of the reasons why intravenous doses of medications are higher than or are lower than oral doses of medications, because the liver metabolizes all these pieces as they come through and takes out quite a bit of medication. Varies between medications as to how much is lost in what's called the first pass effect. Right? So the first pass, oral medication is taken, it is absorbed in the GI tract, it rolls through the liver metabolizes. So it's very highly vascularized, a lot of blood flow, and liver biopsies can be extremely dangerous, especially if the patient already has a clotting or a bleeding abnormality. So GI intubation. You'll be learning this in second term lab, how to do this. NG tubes. NG, nasogastric, versus the OG, or orogastric, or PEG, PEG, percutaneous endogastric. Right. So NG tubes, nursing, providing oral and so oral care and skin care, as with tubes comes pressure, with pressure comes skin breakdown. Verification of the NG tube placement. Again, you'll have more of this in Nursing 204, but your gold standard is, until the placement of that NG tube is verified, you will put nothing but air down that tube. Because the tube enters through the nasopharynx, comes down, and what two systems share piping for a good deal of this pathway? Respiratory system, the lungs, and the GI tract. That tube can end up in the lungs, and if you have not verified placement prior to putting anything but air down it, you will fill their lungs with medication or tube feeding. Generally contraindicated. Removing the tube. Again, you will cover this more in depth in Nursing 204. I will say this, that when removing the NG tube, it is steady. It is fairly quick and steady, pulling that tube out, but not like you're trying to start a lawnmower. When removing that NG tube, it's not grab it and rip, because you're going to do some damage. Our common GI tubes, both for suction and for feeding, the Levin, Salem Sump, Blakemore's. The Salem Sump is probably the most common tube that you will see in general bedside practice. It's a dual lumen tube that allows not only medication or nutrition administration, but also allows for gas venting at the same time. Again, more on that in Nursing 204. So, gastric suction, why would we do this? All right, well, to get a specimen. Okay, that's to treat intestinal obstructions. Here's where a story comes in. So, in nursing, we tend to use the term crappy quite a bit. Patients got, that vitals are looking kind of crappy. It just looks kind of crappy. Those got really crappy lung sounds. Now, we're not using this in documentation. This is talking back and forth between nurses. So with the intestinal obstruction, I actually had a patient who had literal, in the proper use of the term, crappy lung sounds. Patient had been admitted, had not had a bowel movement in 2 weeks. Patient had an intestinal obstruction. Patient was going into respiratory distress. We placed an NG tube and immediately got a large amount of, well, for no better description, fecal matter from the NG tube to suction. The patient had a bronchoscopy, and this was emergent because the patient was in respiratory distress, bronch, and found that, long story short, the patient's small bowel obstruction had backed up. The patient was still eating, still trying to digest, and had backed up from the small bowel all the way up into the stomach, and the patient had aspirated fecal matter, inhaled poo into their lungs, and was going septic. It was not a positive outcome for the patient, but yes, this was a case where the patient actually literally had crappy lung sounds. So treating the intestinal obstruction, draining, keeping the stomach and upper GI tract empty by applying suction. Post-operative distension. Again, that may be one of those anesthesia complications that we've talked about with surgical procedures, because then not only put the patient to sleep, but puts their systems to sleep as well. GI tract motility can stop, and until it picks back up again, until the anesthesia has worn off, as the patient has restarted peristalsis, there will be fluid buildup, backup, and gas production that placing the NG tube will allow to vent off. Okay? Before emergency surgery or after poisonings, to get the stomach empty, because we don't want the patient with a full stomach going in for surgery so that they don't vomit and aspirate. Or after poisonings, to clear any of the rest of that might still be in the stomach out. And then protecting the suture lines after a GI surgery. So if the GI tract has been cut into or cut through and then stitched back together, think about the healing process and how that will progress. So let's say we have GI tract that has been a section of colon has been removed, or a section of small intestine has been removed. The tubes reanastomosed, stitched back together. In the initial phases of this, even though they're stitched back together, there's still not a strong connection. The scar tissue is forming, the tissues are rejoining, and the only thing that will be holding that together until that is complete is the stitches, which are not very strong. So this is a case where we would use gastric suction to keep any and all pressure off of the suture line while the patient heals. So, common treatments: we may place an NG tube for irrigation to wash the stomach out. That's a gastric lavage there. With providing enteral nutrition. So as you're picking up in pharmacology, enteral, parenteral. Enteral is through the GI tract. Parenteral outside of the GI tract. Enteral nutrition, tube feeding. That's given through the NG tube. Again, checking placement, verifying placement before each bolus of tube feeding, so that, because those tubes are very long in an NG tube, they can migrate. And if it has begun to migrate back up, say the patient has had some nausea and some vomiting, and the end of that tube is coming back up, it can get above the epiglottis, and then the tube feeding that you're dumping down the tube gets to pour into the lungs. and then the patient drowns in tube feeding. Right? Parenteral nutrition. This is the intravenous tube feeding, or the not intravenous tube feeding, intravenous feeding. You do not use tube feeding intravenously. It's just, it is not a sterile solution. It is not in a form that the body can use intravenously. Now, let me see if I've got something here. And I'm not okay. Let's pop back up here and reshare this. Nope. There we are. So, parenteral nutrition. Now, this is put together by a pharmacy. This is specially formulated, and it is only good for 24 hours. It is also very irritating to the veins, which is why we do not give parenteral nutrition through a regular IV line, which is only about that long into a vein that is not very large. These are going into the great vessels on the venous side. And they'll be through a Hickman or a portacath or a PICC. P-I-C-C, not P-I-C-K, P-I-C-C. Peripherally inserted central catheter. These are going to large vessels very close to the heart. Surgeries. Okay, so total gastrectomy. Now, ectomy versus otomy, right? Keep in mind, okay, ectomy. So an otomy is cutting into, ectomy is removing, cutting it out. All right, so total gastrectomy, the entire stomach is removed. So then it follows, of course, in the subtotal gastrectomy, part of the stomach is removed. Vagotomy, so here's an otomy, cutting vagus nerve. And then the, well, here they are, work it out with your newly acquired knowledge of medical terminology, gastroduodenostomy or gastrojejunostomy. Where would this be connecting from the stomach to the small intestine? Right? Pyloroplasty. So opening up the pylorus, the pyloral sphincter, right? Which, if that sphincter cannot open fully, it slows gastric emptying and can create some digestive issues, right? Post-operative complications, well, again, a surgery is a surgery is a surgery. Where we are looking at some of these surgeries, the other post-operative complications will depend on the surgery that is done. So like the Billroth 1 and 2, these change the absorption of nutrients. The gastrectomy changes the size of the stomach or completely removes it, which alters digestion. So your complications are going to be specific to the procedure, besides our initial 5, right? The pain, the inflammation, yada, yada, yada. Bariatric surgeries. Now you may have, you may watch the, TLC or some of these My 600-Pound Life and about these bariatric surgeries and think, wow, that's perfect, a surgery for weight loss. Okay, here's the deal. The least scary of all these procedures, the least scary, the one that has the fewest complications, is the laparoscopic gastric band, LAGB. That has the fewest complications, and it can still have complications. These other procedures are incredibly dangerous and can cause complications for the patient down the line. One of which being is if the patient returns to their old habits. These complications from these surgeries and those old habits can be fatal. They're done very often. The patients have to lose a certain amount of weight and make lifestyle changes and be able to prove that they can continue on with those before they're even considered for the surgeries. And also because these surgeries are so dangerous that there has to be a medical reason for doing so. So we'd see these more commonly in patients who have other comorbidities due to being overweight. Bowel diversions, colostomy or ileostomy. The difference is location. Colostomy, so ostomy from the colon or from the large intestine. Ileostomy from the small intestine. There will be a difference in output from each of these. From the ileostomy, it will be thinner, right? From the colostomy, it will be thicker and more formed. There's a scent difference between them due to the presence of bacteria, the state and the state of digestion that the food bolus is in, that the fecal matter is in. Now, patients with ileostomies, I want you to think about the GI tract for a moment here and think about where the majority of water reabsorption takes place in the body. Is it in the small intestine or is it in the large intestine? A little bit of a technical issue there. All right. Minor technical issues. Okay. Here we go. So location, location, location. If we divert before the large intestine, before the colon, the majority of water reabsorption happens within the colon. So if it's diverted before that, then our patients do run a higher risk of dehydration. Okay? Irrigations. We may irrigate the colostomy if the patient is, well, a patient with colostomy can become constipated. So an irrigation would happen there to loosen the fecal matter and allow it to come out. Ostomy appliances, these vary with manufacturer and what is appropriate for the patient. There's a lot of choice, although they are all fairly similar in application. And you get that in Nursing 204, applying the ostomy appliance. So nursing considerations for the patient with a bowel diversion, be it a colostomy or ileostomy. Clothing. So the ostomy may interfere with, or the ostomy and the appliance may interfere with the clothing that a patient would normally wear. There is actually quite a cottage industry that is being built up around patients with ostomies, bag covers, clothing, modified clothing or clothing designed to be worn with an ostomy appliance. Bathing. So the ostomy covered while bathing, because peristalsis does not stop. Activities, um, diet. Diet can be a big one to help address odor and consistency. Skincare. This is especially important underneath the ostomy appliance. The patient has an sensitivity, not an insensitivity. The patient has a sensitivity to adhesives and begins to react to the ostomy appliance. It's not like um, a bandage or a dressing where the dressing size could be increased to move that tape to a different spot. When the irritation or skin breakdown is there underneath the appliance, it is a big deal because you can't just move the dressing. You can't just move the appliance to somewhere where the skin is not irritated. So skincare preventive measures is big with ostomy patients. And then patient and family teaching. These patients live independently. They can live independently. They do live independently. They manage their own appliances. And in most cases. So the patient and family teaching, we need to teach patient and family about all these things, clothing and bathing and activity and diet and skincare. So this would be the ostomies. These would be the incontinent bowel diversions. Continent bowel diversions give the patient a little bit more control over when they move their bowels. So you got the ilioanal reservoir, J pouch, Koch pouch, or a continent ileostomy. These it is allergy season. These different procedures have different considerations as well. Now paracentesis, as you may recall from respiratory, we've already talked about thoracentesis, removing fluid, right? Paracentesis. So abdominal paracentesis, or belly tap, abdominal tap. We're going in and removing collections of fluid from the abdomen. Maybe for diagnostic, maybe for that end-stage liver patient, because liver does more than filter. Okay, it does more than metabolize. It does more than what it also does is it produces proteins, albumin, produced in the liver. Albumin circulating in the bloodstream helps to hold fluids inside the bloodstream, water especially. The thing with water is it is a great solvent. It is a wonderful solvent, and it wants to put everything in solution, wants to put everything in suspension. So if there is a decrease in albumin in the bloodstream, then that water is going to go out and find other things to put into suspension. So when the liver fails and is not producing sufficient albumin, water is moving out, and it will move out into the abdomen. And this is where you have that very large, round, distended abdomen in your liver patients. So the patient may have an abdominal tap or an abdominal paracentesis to remove fluid, because if we have that big fluid buildup in there, we've created pressure, and we have also impaired the movement of the diaphragm. The patient from abdominal distension is not able to breathe as easily. So nurses, we assist with this procedure. course, utilizing our nursing process. Think also about, so if we, as we have talked about with paracentesis, what would we be concerned about as far as the amount of fluid being removed? Okay, true or false? Should they void before the procedure? Yes, yes, because a full bladder takes up space, one, and two, when we're tapping the abdomen, if that needle hits the bladder, then you're going to get a lot of fluid out. It's just, however, going to be poking a hole in the bladder, and we don't want that. We don't want to rupture the bladder. We want to remove the fluid from the abdomen. Mouth disorders. Yes, that's the start of the GI tract, right? So dental problems, missing teeth, cavities, caries, mouth pain. Think about this. If it hurts to chew, how much eating are you going to do? One of my favorite things came out of someone trying to take care of nutrition for people with bad teeth. That would be peanut butter, not the chunky kind, but I do not recall the doctor's name now. It's in the a little bit of a historical piece. Doctor looking for ways to improve the protein intake for his patients with very poor dental quality, right? No teeth, rotted teeth. Ground up peanuts, creation of peanut butter, which when you add 2 slices of bread and a little bit of strawberry jelly is pretty much what I've been subsisting on since the start of the COVID-19 lockdown. Periodontal disease. Again, you got pain. You're not going to feel much like eating. Right? Stomatitis, so inflammation and pain. Candidiasis, oral thrush, again, causing inflammation, discomfort, and taste disturbance. Herpes simplex infections, so cold sores. Trauma to the mouth or to the face, facial trauma, jaw trauma, broken teeth, broken jaw, anything that can impair your oral intake. Precancerous lesions and mouth cancer, all disorders of the mouth. Disorders of the esophagus, esophageal varices. So, when we talked just a little bit ago about the liver and how all of the blood supply from the GI tract drains into the hepatic portal vein, filters through the liver, returns to the circulation. Esophageal varices. So these are veins. Difference between veins and arteries, besides valves in veins, no valves in arteries, is that veins are not robust enough. They are not designed to handle pressure. Your arteries have that nice, thick, smooth muscle layer. Okay, they are designed to handle pressure because they are the vessels on the pump side. So the heart is pumping, it's pushing that blood out with pressure. The arteries are designed to handle that pressure. Veins are not. So where am I going with this? We have all of these veins that are draining through the liver and, into the hepatic portal vein and through the liver back into circulation. Esophageal varices happen because the blood, your liver dysfunction, cirrhosis, hardening, problems with the hepatic portal vein, whatever the issue is that is impairing that blood flow through the liver is causing blood to back up into these veins. And these veins will dilate because there's higher pressure than they were designed to handle, and they get kind of loose and floppy. In the esophagus, These veins are very close to the passageway that food comes through, and so you have these thinned out, full of blood vessels that are now exposed to trauma from food passing through. They can pop, and there's a lot of blood flow that's coming up through that, and that blood is draining into the stomach, which can hold quite a bit of fluid. And often the patient does not really know that they're bleeding until they're vomiting blood, because blood in the stomach doesn't tend to like that too much. So these varices, these loose floppy vessels, can be a life-threatening condition, especially if they pop. And it's very difficult to apply direct pressure to a bleed like that because it is inside in the esophagus. Make sense? Esophageal diverticulum. So outpouchings of the esophagus. Food can become trapped there. Medications can become trapped there. These diverticula can then be places where infections, bacteria breed and cause infections that can affect the rest of the body. Hiatal hernia. So, hiatal hernia. So you've got hernias, abdominal contents, abdominal organs are moving out of the abdomen through a hole or an unplanned opening in the abdominal cavity. So hiatal hernia, the contents are moving up versus, well, long story short, okay, the difference between an inguinal hernia and hiatal hernia is location. Right? These are hernias in different areas. They can all have different effects on the body, different effects on the patient, I should say. Achalasia, heartburn. Who does not have heartburn? Well, if you don't, great. Heartburn, and then Gerd, gastroesophageal reflux disease. Gastric content is moving up through the cardiac sphincter back into the esophagus, which can cause erosive esophagitis, meaning because the stomach was designed to handle acidic. All right, it's designed for an acidic environment. The esophagus, not designed for an acidic environment. Acidic content coming back up into the esophagus is going to break down the tissues, causing erosion, causing pain, causing inflammation. Now, when we're talking about digestive disorders, patients with Gerd have a tendency, certain patients with Gerd have a tendency to be B12 deficient. Okay? And you need B12 to process the iron to be made into hemoglobin. So patients with Gerd may end up anemic from multiple causes. One, you have this chronic heartburn every time you eat. You don't want to eat. And two, the medications, proton pump inhibitors, PPIs, very common over-the-counter proton pump inhibitors for patients with Gerd or with chronic heartburn who have been on these medications for an extended period of time. Not only does the proton pump inhibitor inhibit the production of stomach acid, yay, but it also inhibits the production of intrinsic factor, which allows the body to break down and absorb vitamin B12, which then allows the absorption and the use of iron to dietary iron to form red blood cells. So not only may a patient be anemic from Gerd due to the decrease in PO intake and not getting the building blocks, but also the reduction in production, okay, I didn't plan on that one, of intrinsic factor, which then results in an iron deficiency anemia, or more accurately, a B12 deficiency anemia. Crazy, right? Everything links together. We cover this system by system, but as you are gaining more of this baseline knowledge, think about how this system affects that system. I just gave you one small example of how the GI disorders of the GI tract can affect other systems. And then Barrett's esophagus and esophageal cancer in your book, because we're running late here. Stomach disorders, gastritis, inflammation. Itis is an inflammation. So inflammation of the stomach or the stomach line. Okay. Chronic gastritis, chronic disease, it happens. Toxic gastritis as the result of ingestion of a toxin. Okay. Accidental poisonings. Peptic ulcer disease, these are, all right, so you got peptic ulcers. These are treatable. Ulcers used to be a thing that the patient would just deal with, or possibly have surgery to remove the ulcer. My father was one. He had a partial gastrectomy because he had severe ulcers, and then a couple of years later had another partial gastrectomy. By the way, and this was in the late 60s, so two partials equal the whole. They had the gastrectomy to remove the ulcers. Now we're finding, hey, if it's caused by this lovely little bacteria called Helicobacter pylori, H. pylori, we can treat the patient with antibiotics, and the cause of the ulcer goes away and the ulcer heals. I think, folks, that's why they call it practicing medicine, because they're always practicing. We're always learning something new. Stomach cancer. Well, then, all right, it's a pretty big disorder there, and can go metastatic, and the progression can be really fast. What do we think? Complication from gastritis. So we got chronic diarrhea, bowel obstruction, perforation, toxic megacolon, or dyspepsia, right? Upset stomach. Perforation. So with inflammation, and again, become very familiar with the process of inflammation. Inflammation, we have capillaries expanding, fluid leaking out into the tissues. The tissues themselves become stressed and they become weaker with inflammation. So with the stomach itself inflamed, with that localized edema, the wall of the stomach becomes weaker. Perforation is a potential complication. So, GI meds. You'll be hitting more of this in pharmacology. You got your antacids, okay? Your H2 receptor antagonists, so they're an antihistamine, okay? Proton pump inhibitors, we just talked about that. Cholinergic blockers, right? So they block the effects of acetylcholine, a neurotransmitter, okay? Anti-ulceratives, anti-lipidemics. So getting a handle on that cholesterol level. Peptic ulcer, so antibiotics for peptic ulcer disease, okay, due to H. pylori. Antidiarrheals, okay, well that's kind of obvious. Antiemetics, so medications to stop you from throwing up. And then laxatives, stool softeners, as the patient's condition requires. So let's talk bowel disorders. Diverticulosis and diverticulitis, these outpouchings, these diverticulum of the GI tract. Again, bacteria can lodge there and cause infection. Right? Hernias, inguinal, femoral, umbilical, abdominal, incisional, location. An incisional hernia, if the patient has had a abdominal procedure, the repair to the fascia may not be complete, and then can separate there. Intestinal obstructions and irritable bowel syndrome. Something not completely understood, but it's a syndrome of symptoms due to an irritable bowel. Constipation. Ding, 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 ding. Okay, here we go. Now, the best way, absolutely best way to treat any disease, any condition, absolute best way to treat it, best outcomes, lowest cost, right? Best treatment, prevention. Don't get the disease in the first place, costs nothing to treat the disease then. All right, so constipation for the condition. Fiber, number one. Fluids, exercise. Those three right there: fiber, fluids, exercise. These are and should be cornerstones of constipation prevention. Some medications may be constipating, say narcotic pain relievers, slows peristalsis, lead to constipation. So the patient on those should be getting more exercise, more fluids, and dietary fiber. Fiber, fluids, exercise. Those three right there. But what about stool softeners? They may or may not be needed if you are fiber, fluids, and exercise. The stool softeners may be the next step. With constipation, if we can avoid it, we really want to minimize the use of laxatives, especially in the long term, because patients may become laxative dependent. Diarrhea. Diarrhea poses its own risks. I mean, for the incontinent patient, you have skin breakdown. You have, for all patients, you have the potential for acid-base imbalance, depending on the extent and severity of the diarrhea. And you also have dehydration, because you recall, the majority of fluid reabsorption happens in the large intestine, and if it's flying through so fast that it's not spending enough time in the large intestine, in the colon, you're absorbing less fluid, you're losing it. Okay. Inflammatory bowel diseases. All right, so these are diseases that cause, weirdly enough in the name, inflammation in the bowel. Crohn's disease, one. Autoimmune, hereditary. Ulcerative colitis. So this is an inflammation of the large bowel, which may develop ulcers, which can then lead to perforation and abdominal infections. Appendicitis. Again, this is another one of those pieces where we are learning as we go. A patient with appendicitis in the past may have been scheduled right away for an appendectomy, just removing the appendix. And somebody got smart. We're doing all of these surgeries, all these surgical procedures, which have all of these complications. The majority of cases of appendicitis can be and are now being treated with antibiotics due to infection. Infection causing inflammation. You knock out the infection, the inflammation goes away. In cases where the appendix has ruptured or is very likely to rupture, still do the procedure. But yeah, the majority of cases now with appendicitis that I have seen have been treated with antibiotics. And then no unnecessary surgeries because the infection's knocked out, the inflammation's gone. So cancer, again, we have location, 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 small intestine or colorectal, colon rectum cancer. These treated in the usual ways where you have chemo, radiation, surgery. In cases of the small intestine or colorectal cancer, these are patients that may end up with a colostomy or an ileostomy. And then moving further out, hemorrhoids, anal fissures, anal abscess, anal fistula. Hemorrhoids, so these are dilated blood vessels, often due to clotting or another issue. Okay, much like this is like the esophageal varices for your anus. Okay, they can pop, they can bleed, and they may be the cause of blood in the stool. So we're talking about occult blood. We may do an occult blood test if there's no visible blood. Okay, but if there's visible blood, the fecal occult blood test won't do any good. But what we can see is if there's blood in the stool, is it darker blood? Is it darker, more maroon, almost black? That would be from higher up in the GI tract. But if it's a little bit of frank, bright red, fresh blood, then it is further down, could be from fissure or from hemorrhoids bleeding. Because passage through the GI tract will break the blood down, trying to digest it, and it changes color and consistency. The last, an anal fistula. So this is an opening from the anus to another cavity or another surface. Liver, oh boy. Not just good with onions, a little salt and pepper in a frying pan, but it's very important to your existence on this planet. Okay, so you have liver failure. So where it says here hepatic coma, one thing that comes with liver failure is a rise in ammonia in the bloodstream, which can cause mental changes and level of consciousness changes in your patient. Right? So in liver failure, the elevated levels of ammonia can cause hepatic coma. We have cirrhosis, so we have the hardening of the liver, maybe due to alcohol or drug abuse, medication use, maybe due to other conditions, toxins and or genetics. Hepatitis, inflammation of the liver. Now, not always is it caused by viral or by virus. You may have drug-related inflammation of the liver, which would be that toxic hepatitis, or the other viral hepatitis A, hepatitis B, C, D, and E. These are viruses that can cause inflammation in the liver. Note that we have vaccines for hepatitis B and hepatitis A. Hepatitis D and E are not very common. Hepatitis C used to have no way to cure it. Now, lately, we have seen drug regimens that will cure hepatitis C in most cases. Abscesses in the liver. Trauma to the liver. Remember, the liver is very highly vascularized. Trauma to the liver can cause a lot of bleeding. Liver transplant. So patients with cirrhosis, now with hepatitis, liver transplants can happen. It's hepatitis to hepatitis, or HIV. These patients can get liver transplants. Now, keeping in mind that while you gain liver function back, and this is also an organ that you can transplant part of a liver and it will regenerate. It's really kind of cool that way. But keeping in mind, like any other transplant, it is foreign tissue. It is something that your body does not recognize as its own and will try to attack. So a patient with a liver transplant, while they may regain their liver function, will be on anti-rejection drugs, and that then raises their risk for any and all infections because we're tamping down the immune system. And even with anti-rejection drugs, the body still may reject the organ. Okay. Gallbladder. Cholecystitis, so inflammation of the gallbladder, or cholelithiasis, litho, stone, gallstones, which can cause an obstruction to the common bile duct, or the common bile duct may be obstructed by other things. So the gallbladder contains bile. Liver produces the bile, stores it in the gallbladder. You eat, there are fats that need to be emulsified. Liver produces some bile, and the gallbladder dumps the rest in there. Right? Without bile, fats are not emulsified, they're not absorbed, and they stay in the GI tract. So patients who have had their gallbladder removed often face dietary challenges because essentially if they're eating fatty foods, it's not being emulsified, the fats aren't. And what do we know about fats? Have you ever spilled vegetable oil on the kitchen floor and then stepped in it? It's slick, right? So a patient without a gallbladder, the liver is still producing bile, but there's not as much of it. The fats do not get emulsified and essentially turn the colon into a internal slip and slide, meaning that patients who have had their gallbladder removed have to be careful eating fatty foods, things like fried chicken, or lots of fat or oil containing foods, as it may bring on diarrhea. Pancreatic disorders. I'm going to throw one more piece into this too. So pancreatitis, inflammation of the pancreas. Okay, now the pancreas is an organ of it's an accessory organ of the GI tract. It is an endocrine gland, and it is an exocrine gland, meaning secretes into the bloodstream, secretes onto a surface. Endocrine secretes into the bloodstream. Pancreas secretes into the bloodstream insulin and glucagon, both required for the maintenance of blood glucose levels and getting the glucose into the cells where it can be burned for energy. Okay. As an exocrine gland, it secretes digestive enzymes. Okay, so we have an organ and it is inflamed due to disease process, lifestyle, whatever it is. It's inflamed, and with inflammation comes pain. Okay, and then that patient with the inflamed pancreas then eats something. It's a digestive tract. Digestive tract says, hey, we need some digestive enzymes. Why don't you produce some for us? And what happens? That tissue then goes into production. It's already irritated. So that stimulation of the pancreas to produce digestive enzymes increases the pain. That's simplified, but that's how that's working. So patients admitted with pancreatitis may be NPO, nothing by mouth, for a period of time to reduce the stresses on the pancreas. Pancreatic cancer, the piece that I'll throw in here, you may have heard of pancreatic cancer, and it's like, oh wow, this has a real high fatality rate, and the 5-year survival is not good at all. One of the reasons is that it is so often asymptomatic, or the symptoms are attributed to something else until the cancer has progressed to the point where it is now metastatic. The cases that do best, pancreatic cancer, the people that do the best and have the best survival rates are the ones that it was discovered very early, and very often discovered while their physician was looking for something else. All right, overnutrition and undernutrition. Malnourished, malnutrition. Yes, you can have malnutrition and still be 600 pounds. So that would be a case of overnutrition. Malnourished, obesity, growing problem in the developed world. Yes, I said it. So obesity is more than just overweight. Obesity, body mass is too high due to diet, due to activity levels. And why I say this in the developed world is because, and you'll catch more of this in Nursing 201 when you're talking about nutrition, but our food supply in the developed world, not saying that we do not have a lot of hungry people, but we have a lot of access to food, what I refer to as small F foods, right, versus the capital F foods, which are the ones that are actually good for you. Highly processed, they're cheaper. Small F foods much cheaper than the capital F foods because they're processed to last longer on the shelf. Very high in sugars, salts, and high in sugars is what leads to obesity. When you couple that with lifestyles where we are less active than we were even 10 years ago, especially during COVID land, right? I haven't stepped on a scale lately, but I'm pretty sure that even I have packed on a couple extra because I'm not out and about running around the classroom like crazy. You have a decrease in activity levels, but no decrease in consumption. Actually, in some cases with stress and boredom eating, the consumption probably is going up, which leads to increased body mass, into obesity. And then we have a step above that, well, actually 2 steps now, but where we start to really become concerned is when we talk about morbid obesity, which is a patient who is obese, and that obesity is causing other health conditions. Right? More on that in 201. Now, undernutrition, you may have anorexia nervosa or bulimia, psychological components here. Now, note anorexia nervosa. There is a difference between anorexia and anorexia nervosa. Anorexia simply means they're not eating. Medications may cause anorexia. Disease processes, physical disease processes may cause anorexia. If you don't feel good, or if your choice is, okay, I can either use this time to breathe or I can use this time to swallow food, that may cause anorexia. Patient's not eating. Okay. Anorexia nervosa has the psychological component with it. So the two are markedly different. Bulimia, the binge and purge, again, we have the psychological component here. Their effects, now bulimics may be normal weight, but there are other health conditions that can come in with bulimia. So what do you think? True or false? Is it safe for a nursing mother to be on a drastic weight loss program as long as she drinks water? I really hope nobody said true. No, because the parasite, because when you think about it, okay, the fetus and through the infant until, well, at least 27 years old, ticks all the boxes for parasite, relies on a host, strips the resources from the host, is still relying on the host for all of its nutrition, right? So nursing mother. Now, normally, right, the effect on mom's getting stripped to produce food for baby. Now, when we have this condition where mom's going through this, this crazy rapid weight loss diet, right? You got toxins building up. Those are going into the breast milk. So it's not only dangerous for mom, it's dangerous for baby. Okay. And there are certain things, large amounts of water. Well, yes, most of us do not consume enough water to maintain optimal hydration. For the most part, too much can create other problems, not just those patients with glaucoma or kidney or liver disorders, but heart disease and overconsumption of water. Extreme overconsumption of water can lead to a condition called water toxicity, which can be fatal. Yes, you can get toxic with water. That is it. That is all. I have prevailed upon Bonnie to send you out the stop the share here, to send you out the final study guide. I have this last piece that we'll upload to YouTube momentarily, and with that, see you at finals.